Hello and welcome to the 5th tutorial in our More Than Skin Deep Anatomy series. My name's Connor, and today we're going to be looking at the muscles of the hand. We'll start by examining a clinical case, then we'll look at the anatomy in more detail, and finally we'll return to that case to help put everything into context. A quick disclaimer is that Medsoc accepts no liability for the accuracy of this presentation, and that students are advised to check their course learning objectives. All the images within this presentation are either original or referenced at the end. Our learning objectives for this session are to name the muscles of the hand and to describe their functions, to appreciate the points of attachment and insertion for key muscles of the hand, to understand the structure and function of the flexor tendon sheaths, to appreciate the importance of the extensor hood in the fine movements of the fingers, and to be able to relate the muscular anatomy of the hand to a novel clinical situation. Let's start by looking at a clinical case. This is Sophie. She's 32 years old and she's recently had her first child, Bobby. Over the course of several months following the birth of Bobby, she begins to develop an aching pain in her right wrist and the base of her thumb. The pain is much worse when moving the hand, and when it begins to interfere with her caring for her son, she decides to visit the GP. The GP finds her to be tender over her thenar eminence and the radial styloid process of her right hand. She also has a positive Finkelstein's test, which we'll discuss later. The GP diagnoses her with Quervains Tenosynovitis and prescribes appropriate treatment. Now let's take a closer look at the muscles in the hand. We'll start by looking at the muscles acting on the thumb. The thumb has lots of complex movements, and so it's acted upon by numerous muscles, both originating in the hand and the forearm. And from the anterior surface, where we're looking at now, there are 5 individual muscles acting to move the thumb, and 3 of these form what's known as the thenar eminence, which we'll discuss later. The largest muscle acting on the thumb is the flexor pollicis longus, which originates in the forearm and enters the hand via the carpal tunnel. It inserts into the base of the distal phalanx of the thumb and flexes all of its joints. The first of the short intrinsic muscles of the thumb is opponens pollicis. This is the deepest and largest of the 3 thenar muscles. It originates mostly from the trapezium carpal and inserts into the lateral aspect of metacarpal 1. It rotates and flexes metacarpal 1 in a process known as thumb opposition. Medial to opponens pollicis, but still deep in the palm, is adductor pollicis. This has 2 heads and originates from the capitate carpal and metacarpals 2 and 3. It inserts into the proximal phalanx to bring the thumb towards the fingers in the process of adduction. The flexor pollicis brevis roughly overlies the opponens pollicis and likewise originates from the trapezium carpal. It inserts into the lateral aspect of the proximal phalanx to flex the metacarpal joint. Finally, we have the abductor pollicis muscle, which sits most superficially. It originates from the scapoid and trapezium carpals and inserts in the proximal phalanx to abduct the thumb anteriorly. The opponens pollicis, flexor pollicis brevis, and abductor pollicis muscles form a palmar bulge over the thumb known as the thenar eminence, which we discussed in a previous teaching session. Looking at the thumb from a posterior view, we have 3 muscles acting on it. The first is abductor pollicis longus, which originates in the forearm and inserts into the base of metacarpal 1. As the name suggests, it abducts the thumb away from the palm. Next we have extensor pollicis brevis, which also originates from the forearm. It travels in a common tendon sheath with abductor pollicis longus and inserts into the proximal phalanx to extend the carpometacarpal and metacarpophalangeal joints of the thumb. Finally, we have extensor pollicis longus. This originates in the forearm and inserts via a long tendon into the distal phalanx to extend all of the thumb joints. You'll notice that there's a gap between the lateral 2 and medial 1 tendons. This is a region known as the anatomical snuff box. Its medial border is the extensor pollicis longus tendon. Lateral border is the abductor pollicis longus and extensor pollicis brevis tendons, and its proximal border is the radial styloid process. It contains the radial artery, part of the radial nerve, and the origin of the cephalic vein. Finally, here's a side-by-side view of the muscles acting on the thumb. Feel free to pause here and see if you can remember them all. Next, let's take a look at the muscles acting on the little finger. From the anterior surface, we'll see there are 3 muscles acting here, and these form the hypothenar eminence, which is analogous to the thenar eminence of the thumb. The deepest of the hypothenar muscles is Opponens digiti minimi, which originates from the hook of the hamate carpal and inserts into the medial aspect of metacarpal 5. It rotates metacarpal 5 to oppose the little finger, although to a much lesser degree than we see in the thumb. Next is Flexor digiti minimi brevis, which also originates from the hook of the hamate to insert into the medial part of the proximal phalanx. It flexes the metacarpophalangeal joint. It should be noted that in most people there's no Flexor digiti minimi longus, and that it actually only exists as a rare anatomical variation. So we only actually have brevis. Finally, we have Abductor digiti minimi, which goes from the pisiform bone and the tendon of flexor carpio-ulnaris to insert into the medial part of the proximal phalanx alongside Flexor digiti minimi brevis. Not surprisingly, it abducts the little finger. Here we can see that these 3 muscles form the palmar hypothenar eminence. There are 2 more long tendons inserting into the palmar aspect of the little finger, but these will be covered later. From the posterior view, there is only 1 muscle acting solely on the little finger. This is the Extensor digiti minimi, which originates from the forearm and inserts into the extensor hood of the little finger. It extends the little finger at all of its joints. A couple more tendons do act on the little finger, but these will be discussed later. Again, here we have the 2 views side by side for you to take a look at. Now we'll take a look at the Interossei. These get their name as they exist between the bones of the hand, and they come in 2 sets, the palmar and dorsal, and perform several intricate complex movements of the fingers. First we have the dorsal Interossei, which exist as 4 bipennate muscles. They originate from the shafts of the adjacent metacarpal bones and insert into the proximal phalanx and extensor hood of the related digits. The first inserts into the lateral index finger, the second and third insert into the middle finger, and the fourth inserts into the medial ring finger. The dorsal Interossei generate flexion and extension via the extensor hood, and abduct at the metacarpophalangeal joints. As the thumb and little finger have their own dedicated abductors, they don't require dorsal Interossei. Then we have the 3 unipennate palmar Interossei. These originate from the metacarpals 2, 4, and 5, and insert into the respective extensor hoods. They adduct at the index, ring, and little fingers, and contribute to flexion and extension of these same digits. Here we have the anterior and posterior views of the Interossei side by side. Next, we'll take a look at the long flexors and extensors of the hand. Here we can already see the tendon of flexor pulsus longus, as this was discussed earlier. The deepest long flexor of the fingers is Flexor Digitorum profundus. This originates in the forearm and produces 4 tendons which pass through the carpal tunnel. Each tendon inserts into the base of the distal phalanx of the 4 fingers to flex at all of their joints. Originating from the sides of the tendons of FDP are the lumbrical muscles. The medial 2 are bipennate and the lateral 2 are unipennate. They pass dorsally to insert into the extensor hoods of the 4 fingers and contribute to flexion and extension. Finally, we have the Flexor Digitorum superficialis. This originates in the anterior forearm and produces 4 tendons which also pass through the carpal tunnel. Near the base of the proximal phalanx of each finger, the Flexor Digitorum superficialis tendons split into 2 parts to insert either side of the Flexor Digitorum profundus into the intermediate phalanx. The Flexor Digitorum superficialis flexes at the metacarpophalangeal and proximal interphalangeal joints of the 4 fingers. From the posterior view, we can see the long extensors of the digits. Extensor digiti minimi is already present, as we discussed this previously. Extensor indicis originates in the posterior forearm and inserts into the extensor hood to extend all joints of the index finger. The larger Extensor Digitorum is the main extensor of all of the fingers. It originates in the forearm and produces 4 tendons which insert into the dorsal surfaces of the middle and distal phalanges. The tendons are interconnected in the hand and act to extend the fingers at all of their joints. Here we can see the anterior and posterior views side by side. Finally, we'll look at 2 palmar muscles that don't really fit into any of the previous categories. The first is palmaris longus, which is actually absent in around 15% of people. It originates in the forearm to produce a long tendon which inserts into the flexor retinaculum and palmar aponeurosis, which is just deep to the skin of the palm. Its main function seems to be to improve grip. Lastly, we have palmaris brevis, which overlies the hypothenar muscles. This small muscle originates from the palmar aponeurosis and flexor retinaculum and inserts into the medial palmar skin. This too seems to assist in grip. Next, we'll cover the key ligaments and tendon sheaths in the hand. The metacarpophalangeal joints are reinforced anteriorly by the thick palmar ligaments and medially and laterally by the collateral ligaments. The palmar ligaments are interconnected by dense, fibrous, deep transverse metacarpal ligaments. These hold the digits together and allow them to work in unison. There is no deep transverse metacarpal ligament to the thumb, as this requires a greater, more independent range of motion. Also in the palmar hand are synovial tendon sheaths. These sit within tonals made by other ligamentous structures of the hand and act to lubricate the movement of the long tendons. Specifically, there is the ulnar flexor sheath, which accompanies the thumb flexors, the flexor pollicis longus sheath, which accompanies this tendon only, and the digital flexor sheaths, which accompany the long flexors of the digits 2, 3, and 4. Lastly, we have the flexor retinaculum, which prevents bowstringing in the wrist. Finally, we'll take a closer look at the aforementioned extensor hood. This is formed largely by an expansion of the tendons of Extensor Digitorum and Extensor pollicis longus. The apex is attached to the distal phalanx, the center to the middle phalanx, or proximal phalanx in the thumb, and the base wraps around the metacarpophalangeal joints to attach to the deep transverse metacarpal ligaments, or just the muscles in the thumb. Muscles that insert into the extensor hoods include Extensor Digitorum, Extensor indicis, Extensor pollicis brevis, both Interossei, the lumbricals, Abductor Digitorum, Adductor pollicis, and Abductor pollicis brevis. The intricate design of the extensor hoods allows them to translate force into flexion at the metacarpophalangeal joints, as well as extension of the interphalangeal joints. And finally, we'll return to our case, which was Quervains Tenosynovitis. This injury involves the extensor pollicis brevis and abductor pollicis longus tendons at the base of the thumb. As they share a common synovial sheath, when one becomes inflamed, they both suffer. It's most common in ages 30 to 50, in women, and especially recently pregnant mothers. It's caused by repetitive strain of the tendons in the first extensor compartment of the wrist, and may be linked with rheumatoid arthritis. In our case, the strain was caused by Sophie pulling her son around in a wagon when taking him out for walks. It causes pain in the distribution of these tendons, swelling over the radial side of the wrist, difficulty gripping things, tenderness and hypertonicity of the thenar eminence, and there may also be tenderness in the other wrist extensors. One way to test for Quervains is Finkelstein's test, where you secure the thumb, for example by holding it in a fist here, and you deviate the wrist into an ulnar direction. This increased tension in these tendons should cause pain of the radial styloid process approximately in their distribution. The diagnosis is usually clinical, and the treatment involves avoidance of movements that stimulate the pain, may involve splinting, and might involve a gentle exercise regime, for example using elastic bands, as depicted here. In serious, intractable cases, they may require steroid injections or surgical decompression. Fortunately in our case, after 10 weeks of gentle rehabilitation, Sophie recovered well. She's now back to playing with her son, but no longer takes him out in the wagon. Finally, let's recap the importance of anatomy in understanding today's clinical case. The surface anatomy allowed our GP to infer what structures may be damaged without having to x-ray or open up the patient. Understanding the muscular anatomy enabled us to relate the signs and symptoms for this patient to specific tissues and ascertain the cause. And understanding the tendon sheaths in the hand allowed us to understand the pathophysiology and treatment options available. Thank you for listening. Here's our references for today's session. Please check out our handout in the description box below for a summary of everything we've talked about today, along with some extra information and questions to help with your revision. If you'd enjoyed this tutorial, remember to like and subscribe to our channel. And if you want to see more videos like this, check out our YouTube playlists or visit our website at bhamsurgsoc.com/anatomy.